Hi, everybody, and welcome to the online version of the Montana Spine and Pain Center Understanding Pain class. I am your host for much of this adventure. My name is Amy Davis, and I'm a licensed clinical psychologist here at Montana Spine and Pain, and I've been here for a few years. So just to begin this journey with you, I hope that you are in a comfortable chair, wearing some comfortable clothing, and have your favorite tea or coffee or water in my case, and that you're relaxed and ready to be here. If you're looking up this resource, obviously you have had pain for some period of time, and you're ready or hoping for maybe some new or different information on how to work with pain and how to cope with it. And we certainly hope to be able to provide and offer that today. We'll be going through a little bit about just kind of an overview of what the whole series is like. This is the first part of 8 parts of varying different lengths. And a couple of things before we begin. We will be doing some shared screen work and watching some videos, doing some meditation exercises together in real time. And part of the effort in that is to have it be as close as we can to the class that we would do in person if we were not still in the midst of COVID-19. So although it is really wonderful to meet in person for the social support and to meet other people who are going through similar struggles, I think it can also be helpful to be able to watch and rewatch pieces that are especially helpful for you from the comfort of your own home or anywhere that you happen to be. One thing that I think can be helpful is that as we go along, if there are questions that come up for you, either because I haven't answered them or haven't given enough information on something that you're interested in, it might be helpful to just jot those down with pen and paper. And if the questions haven't been answered by the end of that topic, we would be happy to talk about some of that information with you individually. So this class has been developed in part by me, but also many other fine people who have worked here at Montana Spine and Pain in the past. And so I want to hold up some resources that we will be using in this class. First, we just call it the book. This is a book with the original title, Pain School, developed by Patrick Davis, PhD, my predecessor here at Spine and Pain. And the other Dr. Davis has been instrumental as far as developing a lot of this material, certainly the contents of this book, and just the idea based on really good research that education about pain and how it works and coping with it can be a crucial part of any treatment program for pain. So I'll be referencing this book a lot, and my hope is that by the time these videos are up on our website, so too are the chapters. I don't exactly go over every page of the book, of course, but the general layout is what we'll be following today. And then all of the handouts in the back. So throughout the book, you'll hear me reference, different surveys and different goal planning tools and other assessments that we'll be using as part of that class. And that will hopefully be on the website as well, so that you can print those out, follow along, learn in whatever way is best to you. Another key resource, and where a lot of the newest information on pain science comes from, is the Explain Pain and Explain Pain Supercharged book, written by Lorimer Moseley and David Butler. And those two wonderful Australian pain scientists have been pretty instrumental to our current understanding of how pain works in the brain and in the body, and how we work with it, and why we take a multidisciplinary approach. The other book that I use quite a bit in this class is also by Butler and Moseley, and it's called The Protectometer. And we'll be talking a lot about this, and there will be really specific goals that we will work on based on concepts in the Protectometer. By the way, these are available online. They're a bit pricey since they are not available used, and I think they have to be shipped. But those books are valuable resources for you as well if you'd like more information than what I'm covering in these classes. The first version of this, called Explain Pain, has been out a while, so it might be available online for less money, and it's well worth the read. They use a lot of humor, which I also enjoy, even though we're talking about pain. So I wanted just to talk briefly about what I hope this class is and what I hope it isn't, just so that, you know, we're all hopefully on the same page. What this class is, you know, ideally an interactive experience, which is hard over video, but normally my hope would be is that you would be asking questions and talking about relevant pieces of your experience, or offering up disagreement or clarification about anything that comes up during the class, and doing the exercises along with me, whether it's a breathing exercise or progressive muscle relaxation or guided imagery, and then talking about those experiences. And so, you know, again, I think writing things down can make it more interactive for you. Watching this class with a family member or a friend or someone else that you know who is working with persistent pain, I think can be more valuable. And the other thing that I'll say is that I'm one provider of a number of providers here at Montana Spine and Pain, and I'm joined by physicians, physician assistants, our pain pharmacist, and a number of medical assistants and nurses. And all of us are collectively focused on working with you, mind and body, on this journey of pain. And so this is a piece of an overall treatment program. It is not necessarily meant as an end-all and be-all as far as working with pain. Normally it would be one part of your program here at Spine and Pain. So you might be working with me on pain education and coping, or all the way up to including stress coping strategies and individual psychotherapy, since I am a psychologist. You would almost certainly be working with our physician assistants or physicians to get a good, thorough spine evaluation, updated imaging, and any kind of interventional procedures that our physicians do, whether that would be injections or nerve blocks, or physical therapy prescriptions. And really good physical therapy is going to be a consistent part of what we recommend, whether that's here at Providence or somewhere else. One of the topics that we'll cover specifically talks about the importance of moving the body with pain, even though that can be really hard to do. So this educational program is one piece of a really comprehensive program, also including our pharmacist and what she is able to do. So it's a piece of the treatment plan. It's not meant to be the only one. So that's what the program is. What it is not is meant to be any sort of magic wand as far as teaching you to block out or ignore or imagine your pain going away. I don't have those skills, and I think that would be really hard to do anyway. It is not at all meant to necessarily cover each individual experience. You know, if your pain is related to an injury, or if it's related to a disease, or if a cause hasn't been found yet. Some of the examples in here may not be relevant to you. And my hope is that the information is broad enough to include your experience, but also specific enough that if even one or two pieces of our next few hours together here can be helpful for you, or can teach you something, or offer some hope, that's really what we're going for. So that's what my hope is in this class. And you know, this would be the point in our day where we would introduce ourselves, and I would ask each one of you, you know, what you're hoping for from the class, because you know, one thing I know is that everybody's story is different. You're not just the body part that hurts or the pain condition or any health diagnosis, of course. You're a whole complex person. And regardless of how long you've had pain or have been coping with pain, you're the expert on your own body and on your own experience. And, you know, we are here in order to try to be helpful in any way that we can. And so my hope is that if you do have specific goals or expectations for the class, that you have a sense of what those are before we begin, because that's really important. So this first topic, along with an introduction, is it's called How Pain Works. And so this talk, and then a good part of the second talk, will be about the new science, the most current science behind persistent pain and how we understand it to work. Now, as I've told you, I'm a clinical psychologist, not a medical doctor. So I will be pulling out material and quoting from specific books and using that material directly, mostly so that I don't make any mistakes or errors. Certainly, I know a lot about my field and scope of practice, but when I'm looking at other fields, I want to make sure that I get the facts as accurately as I can. And that's also why, of course, for the medication talk, you will have Dr. Brittany Hobbs leading that discussion, since she is a clinical pain pharmacist. So we'll be off and running. Normally, the way that I structure the classes, other than, you know, we sit down and we have a cup of tea, is that I would invite you to stop this recording, stand, stretch, move around as much as you need to move around, take a break. Normally, we would go for 2 hours total with a good 10-minute stretch break in there, and we'll see if we can incorporate that along the way. That's the good thing about having this on video, is any time that you need a break, you can pause and go stand and stretch, go outside, take some breaths, write down a couple of notes, and we'll come back at it when we're ready. So I'm going to share the screen now with the first PowerPoint slides. It's not that I'm necessarily really excited about PowerPoint, but we want to make sure that visual learners are included and that you get some idea of where we're going here. So let me make sure that I am sharing this screen. Technology. Okay. So hopefully, all right, so hopefully you're seeing these lovely slides, as well as my floating head, and that's what we'll just do together. So we really call our whole program for persistent pain Understanding Pain, or the Guide to Living the Good Life. And that's an interesting title if you consider that having pain is really hard, especially pain that may be puzzling or may fluctuate or may not have a known cause or a diagnosis necessarily, and that is not remitting. It can be really challenging to think about how do we live a good life and work with pain, but that's really what we're here to do. This is some of the acknowledgments again that I just wanted to thank. First of all, Lorimer Moseley and David Butler, who are the authors of the Explain Pain and the Explain Pain Supercharged book, as well as the Protectometer, which is a wonderful, wonderful book with a lot of good information in it. Patrick Davis, PhD, who is the creator of Pain School and the author of this lovely blue book, used to work for Montana Spine and Pain. And he also wrote another book called How to Relax. And Dr. Davis is in private practice here in Montana. So we're really lucky to have him as a resource. My thanks also go to Naomi Lester, PhD, who is a professor of health psychology at Bastyr University, where I did undergraduate work in health psychology. And much of what I learned initially about health psychology And the biopsychosocial model certainly comes from her classes and her research and her enthusiasm. And it's a wonderful program there at Bastyr. And I'll be mentioning many of the different books and studies that we learned about in that program. And then, of course, lots and lots of gratitude and many, many thanks to the rest of my colleagues here at Montana Spine and Pain. We have wonderful physicians and physician assistants and our pharmacist and all of our front staff and medical staff. And I can't thank them enough for being the knowledgeable, generous, kind, and caring people that they are. And we're all here with the same mission, which is to help you. So thanks so much to them. I wouldn't want to do this without them. So this is an overview, not just of today's topic, but of the whole program. And here we are on the first course together, How Pain Works. And we'll be covering a lot of the neuroscience of how pain works and some old beliefs about how it worked and what our current understanding is now. And I think that's important to know because it's really sort of the informed consent if you were, for example, to come in and work with us in person, is that it's fair and helpful, I think, to know what our philosophy is, what our clinical practice is, and what the beliefs and, more importantly, the science behind why we do what we do and why that matters so much. So that's the first topic and a good part of the second topic too. And then we start talking with coping and managing and working with pain directly. The third section is all about physical reconditioning with pain and the importance of moving the body and how that might change with pain from what we're used to. Topic number 4, stress and pain. I think it's a really necessary and important topic for all of us to look at our stress response and what might be adding to that, and then the connection between stress and pain. And more importantly, what do we do about the stress and the pain? Topic number 5 will be devoted to the importance of sleep and the importance of nutritional habits as it relates to pain and just general good health. As I've said before, the medication section will be taught by Dr. Brittany Hobbs, and she'll be talking about oral and topical medication for pain, some safety concerns with medications, but then also hopefully nutritional supplements and foods as well. The last 2 sections are devoted to kind of the cognition around pain and our own experience, as well as the emotions that come up related to pain and just in general. And they're separated out into 2 topics, but of course, a lot of times our thoughts and our feelings and physical sensations all come up at once. So this gives you a roadmap of what we're doing and where we are. As far as how to use the course material best, I think it is really helpful to at least have the first one and the second one before, if you decide you're going to kind of skip around and check out different topics, which is totally fine. But I think the first 2 sections, so this one and section number 2, give an overview of the neuroscience, and we talk a lot about DIMS and SIMS. And that may not make sense unless you watch the first 2 sections before you switch around. So speaking of DIMS and SIMS, let's talk about that now. I'm going to offer just a brief couple sentence explanation of my understanding of what Lorimer Moseley and David Butler mean about DIMS and SIMS and why it matters with pain. Because we'll be using that language a lot, and it will also inform a lot of the goal setting that we do. So first of all, DIM stands for danger in me, and SIMS stands for safety in me. And so Moseley and Butler talk a lot about, remember the DIMS and the SIMS. And I'm just going to read this right off of page 16 in the Protectometer, because I think it's just very clear. A DIM, danger in me, is anything that is dangerous to your body tissues, life, lifestyle, job, happiness, your day-to-day function, a threat to who you are as a person. A SIM, safety in me, is anything that makes you stronger, better, healthier, more confident, more sure and certain within and about yourself. There are 7 categories of DIMs and SIMs. We'll give you a few examples below. So the 7 categories of either a DIM or a SIM, and we'll be working with these each time, are things that you see, smell, taste, and touch, things that you do, things that you say, things that you think and believe, places you go, people in your life, and things happening in your body. And a lot of what this book is about is based on where your protectometer is. So based on the amount of SIMs and the amount of DIMs and where our focus is, will be what our experience of pain can be reflective of. So in other words, the protectometer indicates the overall level of danger or safety in you, and it moves up and down in response to any credible evidence of danger or safety in your life. So we'll go over this in much more detail, but I wanted to introduce that concept right away. And this quote from page 14 sums up what I'm talking about. You will have pain when your brain concludes that there is more credible evidence of danger related to your body than there is credible evidence of safety related to your body. Okay. And danger and safety are pretty broad, pretty important words. And we'll be talking a lot about what those mean and how those translate to a lived experience that includes pain. Okay. So moving on. The other thing that's absolutely crucial to understand, what we here believe at Montana Spine and Pain, not just what we believe, but what we know, what good clinical scientific research shows us, what our own experience over years of working with patients, and in some cases working with our own pain experiences as well, is that no matter what, we know that pain is always real. It is always real. None of us here is operating from an assumption that pain is imaginary, somehow not real, or in some way, not actually happening and perceived in the body, okay? And I stress that point so much simply because when we start talking about the neuroscience of pain, and pain being a top-down process from the brain down and then back up to the brain, sometimes that can be misunderstood by folks to think that what I'm suggesting or what somebody else is suggesting is it's all in your head as if you're making it up. And that's not what we mean at all. Pain is absolutely always real, no matter what. And that is our operating assumption about pain in general and about pain that people come in and talk with us about. So I want to hear from you if that's different than what you have heard from other providers, right? And this would be a point where we would talk about, some of the experiences that you may have had with other providers or with family members or other folks who may or may not understand that pain is always real, no matter what. Oftentimes those experiences can be distressing and really invalidating feeling if it is suggested by someone that somehow pain is being exaggerated or even made up. And I just again want to say that is absolutely not what we think and not how we work with people. And I think that's important to know. What we do know, and this is one of the other main pieces about danger and pain, I've kind of lumped them together because I think What is fascinating for me to have learned in this process is that we don't actually have sensors that are specific to pain. We have what are called nociceptors, or sensors that pick up on possible threat or possible danger. And the word possible is really important there. So I want you to keep in mind that among all of the cells and neurons and the tiny geniuses that make up the physiology of our brains and our bodies, what we have are nociceptors that attune to possible danger to the body, not just necessarily to pain. More on that later. This is another key idea that I'll try to explain, and you'll probably hear me repeat more than once, because it's so important that I articulate it well enough and carefully enough that it not kind of make you want to shut this recording off and leave and go do something else. What we know about the threat detection system, and by that I mean the brain, all of the neurons in the brain that make up the brain, all of the contextual experiences, the emotions, the thoughts, the sensations, the experiences that you've had related to pain, however it was caused. So all of those experiences, the nerves running up and down the spinal cord, out into the periphery, all the tissues of the body, all of that is interconnected, of course, and all of it can be a part of a pain experience. What we know about persistent pain, though, is that pain may not be a really good, clear, accurate indication of what's going on in the tissues. What do I mean by that? So we'll talk about acute injury versus more persistent pain later on. But pain may or may not give us accurate information about the level of damage that's actually happening in the body right now in the present. Again, this doesn't mean that we're suggesting that pain is not real or that pain is not really intrusive and causes suffering. We know it does. But part of what we want to be curious about here at Spine and Pain, and why we have experts at spine-related pain and nerve-related pain, is because sometimes the pain is not connected to what the tissues are doing. Sometimes it can be a combination of other things that are driving pain up. You might be saying at this time, okay, I get that and I can go along with that idea. Or you might be saying, what does that mean? It's not in my head. I feel it in my body. I feel it in my back. I feel it in my joints. Yes, absolutely. But the level of pain that we're experiencing, if we really think about what these scientists are saying in the protectometer, the level of pain that we're experiencing from moment to moment may not be, and often isn't, an accurate assessment of how much damage is happening to our tissues in the present. It can very much be that balancing equation, again, between our perceived level of safety, so the SIM, or the perceived level of danger. And there are a number of different factors not related to what's happening in our body that can really change the difference between whether or not we are feeling safer in a given moment or whether or not we're feeling under threat. Again, just to remind us of all of the categories of the DIMS and SIMs that we have, things that you hear, see, smell, taste, and touch can be a DIM or a SIM. What would be an example of that? Are there things that you hear, see, smell, taste, or touch that immediately bring about for you a sense of calmness and well-being and relaxation? Let's take a moment, because we're going to do this at the end of this topic. Let's take a moment right now, if you have paper or you're sitting talking with somebody else, and just for a moment, think about the things in your day-to-day life that are things that you hear, smell, see, taste, or touch that are immediately relaxing for you, comforting, reassuring, and frankly, stress relieving. Okay. and allow that feeling of well-being in your life. For me, it depends a little bit on the season, but certainly the smell of freshly brewed coffee is a wonderful smell and a wonderful taste. The sight of all of the budding and flowering trees and bushes right now as spring comes to Montana, and the smell of the lilacs is always a wonderful thing for me. The texture of how my dog feels when I pet her, and even just seeing my dog will be a really wonderful, relaxing sight for me. Now, some of these can be both SIMs and DIMs. So for example, I really love the smell of the fire in the fireplace. It's a wonderful, wonderful smell. Or a campfire being outside. And in that context, that particular scent can be very much a SIM because I understand the context of it, right? I'm sitting around the campfire with friends and family, looking at the stars and the mountains, okay? Or I'm in my home with a fire in the fireplace, feeling really cozy. So there's a context for that smell. But what if I'm outside and all of a sudden there's a billowing cloud of smoke coming over a mountain and I smell that smell? How likely is my interpretation going to switch from I'm feeling really relaxed and camping to, uh-oh, something's on fire and I wonder if it's coming toward my home? So take a moment and look over the list that you've written down about things that you hear, see, smell, taste, or touch that are SIMs for you. And remember those other categories, things that we do, things that we say. Our language about ourselves, first of all, is really powerful. How we talk to ourselves, how we describe ourselves, how we talk about our pain, how we describe our pain to others, if we talk about our pain to others, that's really important. Things that we think and believe about ourselves, about our pain, about life in general. Places that you go can certainly be SIMs or DIMs, right? Normally, if this class was in person, it would be in a conference room that we have, and if I'm honest, there aren't windows in there, which can be challenging. The chairs are probably not the most comfortable chairs, and the room is kind of a long square. So it's functional, but it's not necessarily what I would describe as a SIM. If I really wanted to have, kind of my ideal, I would have us be outside in a park, in the sunshine and in the fresh air, gathered around in a circle where we can all see one another, maybe watching dogs go by or outside in nature. That to me would be much more of a SIM experience if we can do that. People in your life, certainly some people in our lives absolutely are SIMs. We see them or talk to them and we just immediately feel better. And hopefully, a lot of those people work in healthcare. That's what we hope. And some people in life are DIMs. Some people our threat detection center increases when we see them. And that can be about our actual relationship with them. That can be about, a past experience with them or who they are in our lives. If they're kind of a stressful coworker or a stressful boss. And some people can be both, of course. People can have moments where they are wonderfully relaxing to be around and calming for us, and at other times stressful. And then things happening in our body can certainly be DIMs or SIMs. So a lot of different categories here. To go back to what this slide is saying, what we want to be curious about is to what extent that persistent pain that we're having, to what extent is that related to what is actually happening in the tissues now? And so one of the things that I've learned as a result of this process and talking to lots of physicians and physician assistants is that if, for example, there is an injury to the spine or to the back or to the muscles, most of the time, unless there's re-injury, those tissues in the body have healed as well as they're going to in 6 to 8 weeks on average. So if pain has persisted past that time, something else is maintaining it, something else is going on. But the amount of pain that we're experiencing may or may not be related to what is actually happening with the tissues in the body. So one of the things that we want to do in the course of this whole program is begin to uncouple the idea that pain, especially with movement, always means, uh-oh, something's wrong, I'm hurting myself. And that's a really difficult idea to work with and to start uncoupling. And we'll talk about that coming up, because that's our immediate internal response. That's how our brain is hardwired to assume that pain is possibly dangerous or possibly threatening, which in some situations it can be. But with persistent pain, what if it's not? And our curiosity about really, what if it's not related to tissue damage, is what the whole program is about. Okay. Questions about any of that? I wish I could hear and respond to your questions. And what I would say is, just keep writing them down. And if we get to the end of this topic and there's a question that still hasn't been answered, it's likely an important one. So pain is such a complex phenomenon, and an experience of pain involves many different parts of the brain. So, you know, in some cases, it would be helpful to think, well, if pain is located in one specific part in the brain, if we could just go in and numb that part out or stop it from working or surgically remove it, poof, we'd have no more pain. It perhaps sounds tempting to do that. And there is, I forget what it's called, but there is a very rare genetic disorder. And I think it's been the subject of at least 1 or 2 movies where someone is born without the ability to perceive pain. And unfortunately, when those folks actually do have serious injury or inflammation from, you know, an appendix that's about to rupture, they're not able to perceive it. And so they're not able to respond appropriately to pain and the threat that pain might indicate. And so they don't tend to live terribly long. But pain experiences involve many, many different parts of the brain. And again, whether this is pain that results from a specific event or injury that we can go back and remember, that certainly involves all of the parts of the brain that remember the event itself and can describe that with language and describe that to others. The emotions associated with that is a different kind of memory, usually stored in the amygdala and the hippocampus if it's really a distressing memory. Any kind of emotional or somatosensory experience, so all of the different sensations in our body and our interpretation of those. Pain is also a part of those processes. And we may notice that pain is really, really contextual. In other words, our pain may be worse if we're in stressful situations or in locations that we associate with stress, like a medical setting, or a hospital, or an emergency room, or a doctor's office. If those are difficult settings for us to be in, we may notice that pain goes up. We may notice that pain improves if we're out in nature, or if we're with our best friend, or if we're walking the dog. What does this mean? Does this mean that, you know, again, pain is imaginary and isn't real? No, absolutely not. Pain is always real, but it's always based on context, and the experiences involved are in many different parts of the brain. So we are not able at this time to find one specific spot and remove that pain, if we would even want to do that. maybe dial it down a little bit, which is a lot, again, about what our treatment program is about. So pain experiences involve many different parts of the brain. And as we'll see, some pain experiences are related directly to tissue damage that has happened in the body with an acute injury, and some are less related to what is actually happening in the tissues in the present moment. And that news is actually really, really hopeful for us. Okay. So we've talked about DIMS and SIMS already. Again, one of the most hopeful things for me that I've been learning at my time here at Spine and Pain in the last 4.5 years or so is that pain fluctuates based on context and based on whether or not where that protectometer is, based on whether or not we have a perceived level of threat or a perceived level of safety from moment to moment to moment. And it's likely that we'll have some of both, but it really is about where that balance is for us. And one of the interesting things too that I learned that's pretty remarkable is that pain is an output of the brain. Pain is an output of the brain that is meant to be protective. And if we think about kind of the evolutionary purpose of pain, right? Pain is an indication of, hey, stop doing what you're doing. You've injured yourself, take your hand out of the fire. Don't cut yourself with a knife. You've twisted your ankle. Stop and pay attention to what's going on in the body. So we have evolved and are hardwired at the neuronal level to have pain be a protective output with acute pain. However, with persistent pain, and again, we think, we know, we believe, we understand that tissues have healed as well as they're going to in about 6 to 8 weeks if we haven't re-injured something. So if pain is persisting beyond that time, it's likely that one of the things that's going on is that we have an overprotective central nervous system, brain and spinal cord. One of the things that can happen that is both an advantage and a disadvantage with pain is that we're bioplastic and we're neuroplastic, meaning that how our brain functions and the speed with which nerve impulses are sent from the brain to the rest of the body and vice versa changes based on our experience. So here's an example. We change how our brain functions and we change neuronal connections when we meet a new person, when we learn new things, if we learn a new language or how to play a new instrument. Our brain changes in response to stress or to depression. Our brain certainly changes in response to grief. It also changes in response to falling in love. Our brain changes in response to physical activity and learning different physical activity, right? So because we are bioplastic and neuroplastic, it means that we have the ability to reshape and change and work with pain, again, at the level of where it comes from, which is the central nervous system. The bad news about this is that our brain function also changes in response to pain that persists, partly because our behavior changes. The brain tends to be tracking pretty closely where our body is in space, how active we are, what our self-care is like, if we've changed our routines, all of those things. That's the bad news. The other not so good news is that persistent pain over time, our brains and our nerves in the spinal cord and in the periphery become more efficient and faster at sending messages. So that closed feedback loop of persistent pain, we become more skillful at that, just like we do with everything else that we learn. A really good example of this would be if you think about the first time that you had to find a new location that was going to be your workplace, or since I'm here in St. Pat's Hospital, if you've been to St. Pat's Hospital, the first time that you had to come here and figure out, where to turn and oops, there's construction over there, Now I got to park. Am I going to park outside? Am I going to go down there? What floor am I going to? All of these different pieces, right? You had to put in a lot of attention and a lot of effort in order to be able to drive here, park, get to your appointment. Once you've done that a few times, much of that function becomes automatic. How? Well, we've learned it. We don't have to pay close attention to it anymore because it's on automatic. But what's actually happening here is that our brains have changed in response to specific behavior patterns, and that has become faster and more efficient. In other words, we are neuroplastic and we have learned how to do this whole complicated set of behaviors that was involved in getting in the car or on the bus and going to St. Pat's and going to our appointment. Now we don't even think about that. Our brains have changed in response to that experience. So the really hopeful news here, the really wonderful hope in the neuroscience is that we are neuroplastic. So even though brain function has changed in response to persistent pain, and we'll see specifically how in a little bit, the good news is that with active, intentional behavioral changes, we can help shift brain function away from overprotecting with pain. But again, the nugget here at this point is every pain story depends on context. Everybody's context is different, and you're not going to be the same day to day to day. And pain is a protective output of the brain. So knowing that, and knowing we can't go in and remove the section of our brain that is responsible for pain, because it's really, really complex, how, if we do have an overprotective central nervous system, how do we help begin introducing some quieting, calming strategies? Again, that's what our whole program is about. That is the purpose, oftentimes, of some of the interventions that our physicians do, some of the medications that we do, some of the movements that we suggest, and hopefully what this class will show you. So there's hopeful news in neuroplasticity. And we've talked about this, but here's a really good illustration of what we understand about persistent pain. Again, pain is a protective output of the brain. It is oftentimes not a good indication of what's actually happening in the present in the tissues if it's persistent pain. But pain is absolutely real. No ifs, ands, or buts about it. Pain is real, no matter what. And it depends on the context. So here's the picture of the fire alarm here. If we think about, you know, the fire alarm is there hopefully to let us know when there's a fire in our house. But what if the fire alarm is either random and just kind of goes off regardless of what's going on, or what if it's so oversensitive that it goes off not just when there's a fire, which we hope doesn't happen very often, but it goes off when the coffee's done brewing. It goes off if, you know, wood smoke blows in from outside the window. It goes off if you burn something on the stove. It goes off if you make toast. It's going off all the time at anything that might be even close to fire. That's basically the metaphor for what we think is happening with an overprotective central nervous system response to pain. In other words, the brain is overprotecting by sending those pain alarms really, really, really frequently, rather than we have pain when it actually tells us something new or different about what's going on with the tissues. It's hard to live in a body where those pain alarms are continuous. And because all pain is real and we go through that experience, it can be hard to grapple with the idea that, wait a minute, this is an overprotective response. My body, my tissues might actually be okay. All right, so how to quiet down those alarms? Because regardless of whether or not there's a fire in our house, hearing the alarm going off all the time gets really, really tiring. Ideally, what we want is that the alarm will be attuned enough to go off when we need it to go off, when there's actually a threat, but not go off at the other times when there isn't an actual threat. That's our hope in working with pain. We have talked a little bit about this before, and just to remind, with the protectometer, that's really what this book does a lovely job in describing, is that there is an ongoing calibration that we are making, mind, body, and also spirit, if you go there. And I think about, you know, the meaning making, the story, the narrative, everything that goes up and becomes involved with a pain experience. It's not just pain from a broken shoulder or a broken hand or a low back injury. It's all of the thoughts and emotions and feelings about that experience, and what our level of threat and our level of safety is with that. And if the balance of possible threat, both internally and outside of us, is greater, the likelihood that pain will persist or even increase is higher. So some of what we want to do is be able to reintroduce to ourselves, how do we interrupt and downregulate the brain, and work with some of the factors that are going on so that pain can also downregulate in a helpful way. Another key point and an important takeaway, especially from this first section, is there are a lot of different treatment strategies for pain, and we find that the most effective ones are the ones that are more active. Here's why, and I don't just mean physically active. I mean involving you as a participant, involving your particular narrative, your particular questions, your situation, your experience, your specific functional goals, rather than what our goals are for you. And active in the way of learning about pain, thinking about pain, talking about pain, and being open to trying something new, which obviously you are, or you wouldn't be sitting down and spending time watching these videos. We also think active treatment strategies are more helpful in that we are human beings who tend to feel a bit better if we have some control and some agency in our lives. In other words, if there's something that we can do. That also works when we are in treatment for our persistent pain. This is really important, and it's not an assumption we make that everybody comes to us feeling really in control and like they are really hopeful about their pain. In fact, a lot of times when people come to us, they have been dealing with pain for years, and it does not seem to be getting better, or it seems to be getting worse, and nobody has found the cause or a treatment that can help. And so the level of depression and sadness and hopelessness sometimes is really, really hard. But I guess it depends on how we define active. So right now, the fact that you are spending time watching this course, and that you're open and curious about what we might know and what we might have to offer, at least enough to have made it this far, is an active participation, right? The other active treatment strategies available are things that we'll talk about, and those can involve being actively involved in looking at our own sleep and eating and stress levels and other lifestyle factors, which is always helpful to do for good mental health and physical health. Very, very important also for pain. Moving toward physical activity rather than avoiding it or minimizing it because of pain, and that's going to be a whole separate topic because that's so important. But anything where we are directing our own program of neurobehavioral rehabilitation from pain, which is what we're doing. So neurobehavioral rehabilitation, using our behaviors intentionally and purposefully to help our brains stop overprotecting with as much pain and help downregulate and begin to shift how our lives are going for us. And we know from good research now and lots of years of clinical practice that learning accurate, current, scientifically based information about how pain works and how to work with it is absolutely essential. We're cognitive creatures, right? We are thinking, hearing, analyzing, questioning, remembering other things that we've learned, and we do all of this very quickly. And again, it's about self-efficacy. If I feel like I can understand how something works and I can apply that to myself and my own experience, I begin to feel as though, okay, I have some control over that. I have some idea of how that works. I have some idea of the theory or the science behind why somebody is telling me about pacing and the rule of 2 for physical activity, for example. I can understand that. So learning about the most current scientific and clinical practice about how pain works is absolutely essential. And again, please don't think that we don't understand and respect your experience. You are really the expert of your own experience and of your own body. No matter how much we know, I can't beam myself into your body and experience directly what you're experiencing. I can't do that. And in some cases, you know, it would be helpful at times, I think, if providers or family members could, for even an hour, to be able to beam into your body, into your pain experience, and literally walk in your shoes. I wish in some ways that we could do that. I can't do that, but I can respect that you already have learned a lot about your pain and your body and coping with it, and you have a lot of skill already in that area. What we also bring, in addition to your lived experience with your pain and what's happening in your life right now, is, I think, the science and the practice behind how we want to help you rehabilitate yourself. So learning about it is absolutely essential. It doesn't mean it has to be, you know, unpleasant or boring, hopefully. So we will also be doing different things, such as some quieting practices, some stretching, some humor, some goal setting, and all those other things that we would do together in person. So learning about how pain works is an essential piece of working with pain, and beginning to go back to the valued life activities and things that maybe you were doing or enjoying and stopped doing with pain. So just a moment to pause and to thank you for being here and being open and willing to learning about pain, in addition to all the knowledge and expertise about yourself that you have. And so here is, you know, by the end of all 8 sessions, what we hope we've covered: neurobehavioral rehabilitation, or using our own guided, directed, intentional skills to help our brains rewire, starting with knowledge. The next piece, that assurance of safety piece, finding out what is and is not safe to do based on your particular physiology. And again, you know, what we're best at here at Montana Spine and Pain is spine-related pain, nerve-related pain, those kinds of things. There are some sorts of pain that we are not necessarily experts in, like, for example, abdominal pain that is not related to spine stuff. Some arthritic pain, like rheumatoid arthritis, some of those kinds of things. That is not necessarily in our area of expertise. Fibromyalgia related pain, although we do have a number of patients with fibromyalgia, there are some areas that some of this may or may not apply. When we're talking about pain related to spine or nerves, and all of the physiology associated there, I, as a psychologist, would never presume to just look at you and say, yep, you look totally good. You're totally clear for PT, and you're totally clear to begin an exercise routine. Thank goodness I work with physicians and physician assistants, because what we would really want is somebody who's very qualified to do an examination and look at your imaging, get very good updated imaging to be able to work with you and show you directly what they see in your imaging, and hopefully be able to offer you the assurance that, yeah, you are clear to resume whatever physical activity that you're hoping to do. Oftentimes it's that assurance of safety that can really help us start pulling apart the idea and the conditioned response that we have as human beings, that pain always means, uh-oh, something's wrong, I'm in trouble, I need to stop and not move. That's an instinctive response, and we've evolved that way. But if we've got that assurance of safety from somebody who's trained and qualified to make those recommendations to us, then we can start being curious about, all right, so let's pull apart this idea. Pain is always real and painful, but it doesn't necessarily have to mean that we're in danger or that pain is threatening somehow, that we're hurting ourselves or causing new damage. That's a really, really important idea. And this would be a good point, if you have thoughts about what I've just said, that pain can be painful without necessarily being dangerous or threatening to us. I want you to write those down, whether you're in agreement or whether you're in open disagreement or anywhere in between. Because that idea, once we really begin to understand that pain can be really painful and unpleasant and all of the other meanings that we would assign to pain without necessarily being harmful to us or causing us to have to worry about, uh-oh, am I causing new damage? We can pull those two ideas apart with and only with assurance of safety from a qualified medical professional, right? Reclaiming life activities, so valued life activities through graded exposure or gradually increasing function or fitness. And I think this is a sensible idea. The gradually increasing part tends to be really hard for folks. Again, if we have lots of memories and lots of experiences of ourselves as being able to run a 5K, and all of a sudden, walking more than a few blocks causes pain, it's going to be frustrating. It's going to be jarring. But the way out of the, either being on the couch or going full out is going to be through gradually increasing function and fitness activities. And functional activity, by the way, are things that we need to do to be able to care for ourselves: dressing, bathing, taking care of our home, getting in and out of the tub or shower, getting in and out of a vehicle safely, being able to care for ourselves, our home, our animals if we have them, our children if we have them. So basic functional activity. And then we talk about fitness activity, recreational activity, work-related activity, and other meaningful activity. We hope that in learning, because each time we learn something, our brains do respond and new neuronal connections are made. We hope that the brain will in fact reroute and rewire along with the spinal cord, where pain can be downregulated. By the way, downregulation of pain is also, again, the purpose of a lot of the procedures our physicians do, like the trigger point injections, the epidural steroid injections, the nerve ablation. Some of the medications are also used to interrupt and downregulate pain as well. Gradually reclaiming function. The quieting practices that we will teach you, neurophysiological quieting activity of working with pain very directly. And then reminding ourselves that our brain also has for every memory of distressing information, unpleasant or noxious information like pain, I would consider pain a pretty noxious stimuli. We also have as many, if not more, experiences or memories of pleasant experiences, which is again why we'll turn so often to this protectometer to talk about SIMS. So one question at this point might be, okay, that's all fine and dandy, but how is talking about, you know, my favorite smells or my favorite past experiences going to help me now? In part because I can't do those things I used to do, and I get really, really sad when I think about all the things that I used to be able to do, and I can't do them now. It's an excellent question, if that came up for you. And to answer that in part, I would say the incredible power of our imagination and our brain is pretty remarkable. And again, I'm not suggesting that we imagine that you don't have pain, but taking the incredible experiential, imaginal, creative potential of our brain and shifting it from focusing on pain, discomfort, what we're not able to do, what we miss doing, and being able to shift it to the things that we greatly enjoy and where we are in the present can be really helpful. So in other words, I'm talking about the power of the mind-body connection and how to help ourselves shift into remembering and exercising the pleasure network of the brain, not necessarily just the centers associated with distress. And we will be talking much more about that. So again, to summarize, I think if you walk away from the first talk with just a few points, this is certainly an important page. First of all pain is absolutely real. Whether medical professionals can specifically pinpoint a cause or a diagnosis, it's real, and we know that it's real. Pain is a protective output of the brain. It's not the only output of the brain, but it is a protective output of the brain. And with persistent pain, oftentimes it is not an accurate message about what is happening in the moment, in the body, in the tissues. Sometimes for better, sometimes for worse. So this particular piece is absolutely essential to understanding, first of all, what we know is current in pain science, and second of all, how we work with your pain here at Montana Spine and Pain. And of course, as always, we need a little bit of a humor break here. You know, my thanks to Doug Savage and the Savage Chickens. I think these cartoons are great. Here, of course, we have two hyenas, and one says, "It hurts when I laugh, Doc." And the Doc hyena says, "I'm afraid it's terminal." So previously, our older understanding of how pain worked was that pain existed or manifested in the body and was observed then by the brain. And the brain's job was sort of like a lookout tower with forest fire, right? So if the brain is the lookout tower and pain is a fire erupting somewhere in the wilderness, it just erupts in the body, and then the lookout tower or the brain observes it and then responds. And that we also thought that pain was a measure of the extent and the accuracy of damage to the body or to the body part. This was a perspective that was not only embraced by patients, but also medical providers. And of course, we have the wonderful illustration here of the fire in the particular body part. So starting in the body part and then being observed by the lookout tower and the brain. We know now that the opposite, in fact, is what is happening. Pain is a protective product or an output of the brain. What happens is there is a response to those nociceptors or those signals of possible danger or possible threat coming from the body into the brain. Notice I said possible danger or possible threat. So pain then becomes an alarm system that lets us know about possible danger to the tissues, but it doesn't necessarily tell us specifically what or how bad. It's more general than that. So for example, that alarm goes something like this. You know, the nociceptors detect something, and the brain gets to interpret it and decide, first of all, is this a signal that is strong enough that it needs a response? And what is it exactly that's going on? Nociceptors pick up on tissue damage, but they also pick up on chemical changes, pressure changes, and also changes in temperature. So it's as though the signals going up are fairly vague. Something's going on, we're not really sure what, could be something. And oftentimes the brain will then interpret and decide, okay, is this going to warrant a pain response, a stress response, a goosebump response if it's cold? What is the response that's being warranted here? There's always going to be the physiologic response. However, oftentimes there's an interpretive response. How often have you seen people wince in pain before they injure themselves? Or how often have you seen folks, especially little kids, fall down? We're not sure if they hurt themselves or not, but when the parent looks over and looks at them, then they start crying. You know, that's probably a more complicated process than that. But basically, pain is an output of the brain in response to nociception, which signals possible threat, possible danger. And it's an alarm system that we have evolved with and that has done a very good job of keeping us alive. It has a high survival value that we have that response. But it oftentimes does not give us an accurate state of what's happening in the tissues. So the question of, okay, so does hurt always equal harm? With acute or short-term pain, we think, yes, you know, pain can often equal tissue damage if the alarm system in the brain is functioning properly. However, it's not always proportionate to the amount of tissue damage. For example, if you think about a paper cut, I want you to recall one of the last times that you got a paper cut or cut yourself on cardboard and how extraordinarily painful that is. And for the most part, it's not a serious amount of tissue damage, but the level of pain is pretty dramatic, right? And then if you think about a time when you did have actual tissue damage, oftentimes initially, especially in the first few moments of injury, even if we have the awareness of, wow, I've hurt myself, we may have little or minimal pain. I think about a particular experience I had right as I was new to spine and pain. I managed to lacerate my forehead in a nice, neat line right across my head, which was, you know, it was kind of one of those things. I was out there raking leaves and I slipped and lacerated my forehead on a lovely recycling container. At any rate, so all of the cues, you know, I knew I hit my head pretty hard, and then seeing blood kind of running down my face into my shirt, knowing that, you know, lacerations bleed a lot, all of that knowing, yep, I've definitely had some tissue injury. I need to you know, get a cloth and head to the emergency department. But there wasn't any pain initially, no pain at all. Sitting in the emergency department, going through the assessment, holding the cloth to my head, blood running down my face, still no pain. And so when they say, okay, on that 0 to 10 scale, how's your pain level? Not much. Eventually though, within about 20-30 minutes, that wears off. And then all of a sudden, wow, there's a lot of pain. So even with an acute injury like that, the level of pain, the timing of pain, how much pain we're getting, oftentimes will not be exactly proportionate to the amount of damage going on, okay? With persistent pain, again, what we think happens is that the feedback loop is closed. So with acute pain, and I'll use for an example, twisting your ankle. We twist our ankle, we know for sure when that happens, we receive pain, and then there's swelling and inflammation. And usually if it's bad enough, you know, for the first few days or weeks even, putting weight on that ankle and moving as normal, we're going to have pain. So of course, the invitation is, you know, take weight off the ankle, ice it, elevate it, do all of those things that you would do. Again, remember, I'm a psychologist, not a physio. So the pain is there as a governor to keep us from jumping on it, putting our weight on it, and going for it. What's interesting though, is that if we really have sprained our ankle, it takes about 6 weeks at least to heal those tissues. But more often than that, if that has happened to you, probably you had the experience that the pain went away in a far shorter amount of time than 6 weeks, so that you can get out and move on it again and rehab those tissues and keep going, right? So if we receive pain before the tissue is injured and then it regulates down before it's fully healed, then that tells us that the system is functioning as it should. It's appropriately protective. With persistent pain, we think that the system is overprotective. And what can happen is there are neuroplastic changes in the spinal cord and the brain that maintain those pain alarms, the frequency, the intensity of them, without there being input from the body tissues or from the nociceptors. This would for sure be a point where I would pause and say, what questions do you have about that? All pain is real. With persistent pain, we feel like there are a series of those false alarms that are going off continually. By false, I don't mean pain isn't real. I mean that the fire alarm is going off just indiscriminately for anything, not just when the house is on fire. And every time those pain alarms go off, based on how we respond to it, do we tense up? Do we guard? Do we brace? Are we really angry? Are we frustrated? Do we stop moving? Do we hyperventilate? Do we get mad? All of those will eventually result in neuroplastic changes in the spinal cord and the brain. And with anything else, we get faster and more efficient at sending those messages, okay? So what started out as a properly functioning pain system becomes kind of a closed feedback loop and becomes self-generating, which often again means that there's not a good correlation between the pain that we are experiencing and going through that is very real and what's actually happening in the present with the tissues. But we are dealing with the pain, right? We're dealing with the pain. And what we want to do with this program and then with everything else that we do at Montana Spine and Pain is we want to interrupt that closed feedback loop and begin to slow down and downregulate some of those neuroplastic changes. I wish that I could hear your questions because I can just get the sense that they're good ones. This is a lot of material, by the way, and I love the neuroscience behind this stuff. I find it fascinating, even though I always have more to learn. But if you have questions or you want clarification, a couple of things I would say. This first chapter of the Blue Book that Patrick Davis wrote, the introduction and how pain works, has a lot more detail in there too, and I think that would be helpful. So here's an example, and I almost don't want to call it phantom limb pain because I know there are some folks who've had that pain who, you know, that name is not a particularly good description of their experience. But what happens when, how do we understand pain in a body part that isn't necessarily there? Or not just pain, but any sensation. in a body part that isn't there. You know, people are reporting things like, well, my foot is itching all night long and I'm waking up to itch my foot, but my foot was amputated. It's not there. So what's going on with that? And, you know, is it really just, well, the nerves are doing something strange? It doesn't make sense if we think of the pain coming from the body part, you know, like the fire in the woods, and being perceived by the lookout tower as the brain. It does make sense if we remember that it's actually the opposite. There are some sensations of possible danger going to the brain. The brain is interpreting and offering the protective output of pain. So it does make sense if we remember that that output is actually coming from the brain, not from a body part that is not physically there. These images are very interesting, and as you can see, they're asymptomatic images. So these were images done of people who did not come in specifically for back pain. They had imaging done, and they have conditions that we would normally associate with generation of pain, including across this top row, pretty clear disc herniation, degeneration of discs. So really, you know, there's been kind of the collapsing of the discs, and then a narrowing of the openings, right? And all of these images. If somebody came in with back pain and we looked at these images, we might correlate those and say, okay, you know, this looks like what might be generating your pain. But these people have what is described and what is seen as clear spine pathology, but no pain. So how do we explain that? Well, because the pain may or may not have anything to do with what's going on in the body part. And in these images, we have people who have degeneration of their discs or herniation, but who are not reporting pain. Pain is a protective output of the brain. So too, the opposite can be true, and I know this can be frustrating for patients where they do have low back pain or neck pain, and then we look at imaging and there doesn't appear to be, or there's not discernible, a clear pathology of the spine that would also correlate with the pain or the symptoms that they're reporting. It can be frustrating for patients, but again, I want you to know, whether we can clearly see in imaging or not, we know that all pain is real, and that's how we work with pain. But sometimes what can be misunderstood by patients, or if we're not careful to explain, is that people will say, well, yeah, you know, they did an MRI on my neck and they said everything looks fine. So they don't believe my pain, or they're invalidating my pain, or they're not going to help me with my pain. And that can be really frustrating too. But sometimes imaging shows us clearly what is happening, and sometimes it does not. And interestingly, Lorimer Moseley talks about this too in a couple of his lectures and talks. But even going in to get imaging done on a body part can actually increase the pain in that body part, regardless of what the results are. I find that fascinating. So these are what we call asymptomatic images. So why in the world do we have this system of overprotection or protection with pain alarms? I'm going to stop and have a sip of water, and you let me know what you think the function or purpose of pain is. And normally we would have a discussion about this. Without having the alarm system of pain that alerts us to possible tissue damage and actual damage to the body, we would have a hard time avoiding injury, or we would not respond appropriately to abdominal pain that might mean, you know, our appendix is not doing very well, and we need to get medical attention, right? So pain is a motivation to avoid or get away from dangerous situations or movements that are not helpful for us, or activities that are harming us as quickly as possible. And like we talked about before in the example of the sprained ankle, it can help us limit or govern movement and activity while tissues are healing if they've been damaged, right? If you think about, you know, if you get a sunburn, if you get a mild sunburn, not where you have blisters or anything like that, but you get a sunburn, and then if you hop into the hot shower or the hot bathtub, your tissues will tell you, hey, this is still really sensitive, and you need to be careful. These tissues need protection until they heal. So that's the function of pain. And again, there is such a strong survival value to having the protective system of pain that even the false alarms that we talked about, the overprotective alarms, going off and feeling pain at anything that may even remotely be seen to be threatening, those have a survival value too, right? So we've evolved in part because, you know, the brain decision of it's better to go off more frequently and be wrong about possible threat, possible danger to the tissues, than underreport and miss one that's actually life-threatening, right? So our brain and the way nociception works and the way the central nervous system works is that there is a bias built in toward overprotection with false alarms. That's how we've evolved, and that's how we've survived. Really difficult if you're experiencing that overprotection, but knowing this is a protective mechanism of the brain. Interestingly, as a psychologist, I also think of anxiety in much the same way. Anxiety is a protective mechanism that we go through, okay, that can be helpful at times when appropriate and unhelpful when it becomes kind of a persistent state. So here, as we're wrapping up, this is the second to last slide. So if you're wanting to stop and stretch, good timing. This is where we are setting functional goal planning and tracking. So page 227 in this big blue book, and all of this will hopefully be numbered correctly in the appendix. It talks really specifically about what a functional goal is and how to come up with specific steps that are important to you. So I'll just read this, and you can read this along if you're looking at page 227. So a functional goal is something of a physical nature, which requires use of your muscles, which you want to begin doing, start doing again, or be able to do longer or with increased intensity without experiencing a period of debilitation afterwards, and that you're willing to work toward achieving. Functional goals involve the use of your muscles to perform a physical activity of some sort. So if your functional goal is something specific, like I would like to begin walking my dog again for 10 minutes in the morning and 10 minutes in the afternoon. Great. I want you to go ahead and write that down. And there's a whole list of steps and parts to that goal setting on page 227, because part of what we want to do is have the goal setting that you do be things that are highly motivating and highly valuable to you, rather than us knowing what your goals are or what our goals for you are. So I would like you, actually, between now and the time that we start talk number 2, to spend some time really with, okay, what are your functional goals? What are the things that if you begin to be able to do more of or do it all, that you will know that things are getting better for you, that this program is helping you. By the way, when we assume functional goals, we are not assuming that you will do them entirely without pain. What we are assuming, if you're walking the dog 5 minutes a day, just to give a very specific example, is that if you're walking the dog 5 minutes a day, the pain will not be worse than it is now. That's the initial assumption, okay? Part of what we're working with, again, is the notion that when we have this overprotective system that has learned persistent pain and is over-responsive with pain, it will take some time to help interrupt and downregulate that. So our hope and goal initially for you is that as you do more activity, that pain will not go up and get worse. If it stays the same, we're We're okay with that, even if you're not initially okay with that. If pain goes down, of course, that's lovely. But the idea is to really work on function with pain, okay? Not on we have to eliminate pain in order to then be able to increase activity. That's the hard part. So spend some time on page 227. Usually I suggest that, normally we would be meeting for a total of 8 weeks. So 3 or 4 functional goals that are very, very specific, I think are great. Too few can be less motivating. Too many, we can start to feel pretty overwhelmed. But the Sims, so for next time, what I would like you to do, if you were all here in person, I would want you to go through and think about safety in me, or SIM. What are the things, preferably, daily, that you hear or listen to, that you see, that you smell, that you taste, and that you touch, that are absolute SIMs for you? Unequivocally very easy, right? We don't want anything that's like, well, I sort of like the smell of fresh mown grass, but it makes me sneeze. No, we want the thing that if you were to smell this food, or smell this particular place, like when I walk into Butterfly Herbs and I just smell all of those smells, that it's easily wonderful for me. I want you to think of at least a couple of those, and I want you to write them down. And I would like for you to intentionally spend some time looking at all of the different sensory-oriented SIMs that you have in your life, and notice those. Okay, and there are some other planning pages for you here. There is an action plan form, and a little bit about the kind of the planning forms and the journaling and the keeping of goals. If you're a person that likes to see goals and kind of weekly tracking and weekly progress, and that's helpful for you, great, do that. If you're a person for whom that feels overwhelming or unnecessary, or even worse, it brings up a lot of anxiety, or if you don't do it, you're going to feel stressed out, please don't do that. We are here to be helpful. We're not here to add more stress. This is not homework. Obviously, this isn't something that I'm going to collect for you. I think it can be helpful to track over time where you're starting this program with how you're able to function and where you end up, because it can be really helpful to see progress. But you're going to be the best decision maker as far as if that's a helpful process for you to do, or if it quickly just feels like it's another thing to do and I don't want to do that right now. Okay. And I would say the same thing if you were here in person. This is for you to make sure you're getting what you want and need out of this program. So use it in that spirit, please. And then finally, of course, we have one last cartoon. Oh, this headache is killing me, says the starfish. And the octopi says, how bad can it be? You don't even have a head. I don't know, but probably an overprotective central nervous system. So thank you. My goodness, if you haven't by now, stand, stretch, move around, have some water, go outside, have some fresh air. Thank you so much for being here and for starting your journey with us into understanding pain. And I hope to see you next time.